Hello.
Hello.
Hello. Yeah. Zain, are you ready?
Yeah, hi sir. Yeah, sir.
Yeah. Have you started recording?
Okay, sir. Can I start?
I think so because I think we should start on time so that.
Okay, sir.
Recording in progress.
Okay, right.
We are good to go. Thank you.
Okay, thank you, Zain. Thank you. So, my dear students, shall we start the program? We need some volunteer to discuss the case.
Yes, sir. I will discuss.
Any volunteers?
Sir, good evening, sir.
Good evening.
Sir, my name is Kapil, sir. I am from TD Medical College, Alapur. Finally, it's appearance for practical, sir.
What is your name?
Kapil, sir.
Ashish.
Kapil.
Can you spell for me?
Kapal.
Kapil. Okay, right. Okay. Okay, where are you from?
Sir, Alapur Medical College.
Which medical college?
Alapur Medical College, sir.
Alpram Medical College. Okay, fine. Okay, so I think we will start the discussion. We'll have a case discussion today. So let's hope things will go well. Oh, Zain, you have to give permission for me to share the screen.
Okay, sir. It's done, sir. You can share. Thank you.
Okay. Kapil, can you see my screen?
Yes, sir. I can see your screen, sir.
Okay, right, fine. So shall we start? Okay, right.
Good evening, sir.
Good evening. Where are you actually from, Kapil? Are you
From Tamil Nadu, sir.
Tamil Nadu? Okay, fine.
Yes, sir.
Which are you? Second year, final year? Which year are you?
Just now I have completed my theory, sir. Yeah, I'm waiting for the practical exam.
Oh, you have completed your theory and waiting for the. You are the batch who has just appeared from the Kerala Health University. Okay, very good.
Yes,
Okay,
sir.
yeah.
Yes, sir.
So you must be bubbling with knowledge. Let me find out. Okay, right. Yes.
Try my best. Yes, sir. The 60-year-old male is presented with complaints of exertional palpitation for the past 10 years. Occasional palpitation at rest for the past 2 years and exertional breathlessness for the past 2 years.
Okay.
Sir, I am audible, sir.
Okay, go ahead. We will first read the full story and then we'll discuss the story part.
Patient was experiencing exertional related past regular palpitation for the past 10 years. No significant increase in the gravity of the symptoms till 2 years ago when he started getting palpitation off and on at rest. His palpitation used to settle down after exerting for some time and he could do moderate to severe manual labor. He is an agriculturist and does agricultural activities in his own land. No history of exertional breathlessness during this period. He started experiencing regular palpitation at rest, especially when he is excited or anxious for the past 2 years. During this period, he started experiencing exertional breathlessness, NIGA function class 2. No history of paroxysmal nocturnal dyspnea or orthopnea. No history of irregular palpitation. No history of cardiac pain, fatigue, hemoptysis, exertional syncope, edema of dependent parts, or intermittent claudication of limbs. He consulted a cardiologist 10 years ago who told him that he is having a leaking heart valve and needs regular follow-up. He was prescribed 2 medicines which he was told would prevent the progression of the disease. He was advised early follow-up or earlier if he developed progressive symptoms. Past history: no history of rheumatic fever in the past, no history of heart disease in the childhood, no history of systemic hypertension or diabetes mellitus, no history of spine complaints, no history of exposure to venereal disease. Family history: no family history of heart disease. Father died at 80 years of age due to cancer. Mother is alive. No history of hypertension or diabetes mellitus. Habitus non-smoker and no habits.
Okay, now discuss the story.
60 years old male with history of
Okay, right. Yes. No. Now you don't have to repeat all the age and all those things. Now you should do a step-by-step analysis. First is to decide whether it is a cardiovascular system disease. Is it a cardiovascular system disease? Do you think that this is a cardiovascular system disease, or you are not sure?
one possibility is cardiovascular disease, sir.
Yeah, I think palpitation is an important symptom. So very likely that he may be having a cardiovascular system symptom, cardiovascular system involvement. Moreover, recently he has started developing some exertional breathlessness also. Both put together, you can start thinking that this must be a cardiovascular system disease. And also he was getting recurrent episodes of palpitation at rest. What may be the reason for that?
Palpitation at rest could be arrhythmia, sir.
Okay, what type of an arrhythmia?
So it can be paroxysmal supraventricular tachycardia.
Okay, it can be paroxysmal supraventricular tachycardia. Do you think that it can be atrial fibrillation?
Yes, sir. But the palpitation, what you have mentioned, is regular, sir. And specifically, they have mentioned there is no history of irregular palpitation.
Okay, so since there is no history of irregular palpitation, from the story at least we cannot diagnose atrial fibrillation. Okay.
Yes,
Now, second question that we have to ask, if it is a cardiovascular system disease, then which side is affected? Is it a left-sided disease, right-sided disease, or a both-sided disease?
So left-sided, it can be both-sided, sir, but most first possibility is left-sided disease, sir.
You can't be certain, but you can say that since there is a history of exertional breathlessness, which is more frequent with left-sided disease, I would like to consider first the possibility of left-sided disease.
Yes, sir.
So you cannot rule out the right-sided disease.
Yes, sir.
Okay. Now then, what could be the pattern of involvement? Is it a volume overload? Is it pressure overload? Or is it a primary myocardial disease? Or is it an arrhythmia? What is the problem which actually has resulted in its cardiovascular system disease?
Sir, in the order of hierarchy, first I would like to consider a volume overload pattern, sir.
So what is the reason? What is your reasoning?
It is first initially it's an exertional palpitation, sir.
Okay.
Then followed by he is getting at rest also associated with exertional dyspnea, sir.
Okay. What would be the course of events?
Sir?
What is the course of events? So he has developed initially palpitation, then he started developing some exertional breathlessness, and also palpitation at rest also. So what are the events which has led to these symptoms?
Sir, initially the exertional palpitation is due to the volume overload, sir.
Very good. Volume overload is the commonest condition where the patients can have palpitation, the symptom which can precede all other symptoms for a number of years even. Okay, so
Yes, sir.
he may be having a volume overload. What do you mean by volume overload? Can you mention the conditions where there can be volume overload of the left side, right side?
Sir, left side is mitral regurgitation and aortic regurgitation, sir.
Very good. Any other?
Hypertrophic.
No.
Right sided is a tricuspid regurgitation, pulmonary regurgitation, all regurgitant lesions, sir.
Okay, right. What else? Volume overload means regurgitant lesions plus hyperdynamic circulation. No, shunt lesions. No.
Shunt lesions. Sir.
Hyperdynamic, there is no increase in the volume overload. So hyperdynamic is actually a situation where there is a reduced, the heart is able to pump the blood at a faster rate.
Yes.
There is no increase in the volume of the blood being ejected out. So here the patient is having a volume overload, so regurgitant lesions and shunt lesions.
Shunt lesions. Yes.
What are the shunt lesions which can give rise to left-sided volume overload, right-sided volume overload?
So left-sided volume overload is ventricular septal defect and patent ductus arteriosus, sir.
Okay, these are the two which can give rise to volume overload, mostly affecting the left side of the heart. Okay, and right side?
Right-sided at the level of atrium, it is atrial septal defect, sir.
Okay, so can you mention any shunt lesion where there can be, or an acquired shunt lesion where there can be biventricular involvement?
Yes, sir. ASD itself can have biventricular involvement.
No. ST cannot give rise to biventricular because the LV is spared because the shunt is from left atrium to right atrium, so it cannot have a LV involvement.
Rupture of sinus of valsalva.
Very good. Rupture of sinus valsalva to right atrium or to right ventricle can have volume overload of both right as well as the left ventricles. Very good. Excellent. Okay, right. So he may be having a volume overload condition. What can be the possibility that he is having started developing some exertional breathlessness?
Sir, the exertional palpitation itself can cause dyspnea, sir. Exertional dyspnea.
No, he has been telling that he is able to work very well in the field. There was no problem for the past 10 years. But recently he started developing exertional breathlessness.
Sir, recurrent lesions generally tolerate volume overload for a quite long period, sir.
Very good.
Nearly,
Of the regurgitant lesions, which is better tolerated? Is it aortic regurgitation or a mitral regurgitation?
Sir, aortic regurgitation is better tolerated, sir.
What is the reason?
Sir, aortic regurgitation, particularly, they tolerate exercise-related symptoms, sir. Because during exercise, the peripheral vascular resistance falls, sir.
Okay.
So, as the peripheral vascular resistance falls, the amount of regurgitant volume decreases in aortic regurgitation, sir.
Very good. Second.
Second is
during exercise, what are the hemodynamic changes and what is the effect of these hemodynamic changes on mitral regurgitation and aortic regurgitation?
So, first is increase in heart rate, sir.
Oh, increase in heart rate, yes. When there is an increase in heart rate, what is the effect on mitral regurgitation? What is the effect on aortic regurgitation?
Sir, increase in heart rate decreases the diastolic filling period, sir.
Okay, very good.
Amount of regurgitant volume comes down in aortic regurgitation, sir. Okay. With increase in heart rate, the rate of LV contractility, that is dP by dt, will be higher, sir. Mitral regurgitation, the amount of regurgitant volume will increase with heart rate, sir.
Before that, you can say that when there is an increase in heart rate, what happens to systolic phase?
Systolic.
So, say diastolic phase comes down. What happens to systolic phase?
Contracting. No, sir.
No, the duration over a period of 1 minute. If you consider the systolic phase and diastolic phase, when the heart rate is 60 per minute, what is the relationship? And when the heart rate is 120 per minute, what is the relationship?
Sir, I don't know, sir.
At 60 per minute, usually the diastolic phase is double the systolic phase.
Yes, sir.
And 120 systolic and the diastolic phase becomes equal.
Yes, sir.
So as the heart rate increases, as you rightly said, the diastolic phase comes down and the systolic phase gradually becomes more and more.
Okay, sir.
So when the diastolic phase comes down, the aortic regurgitation becomes
less prominent, sir.
Less prominent. And when the systolic phase goes up, what happens to mitral regurgitation?
Mitral regurgitant volume increases, sir.
Why mitral regurgitation becomes more prominent. So during exercise, the hemodynamic changes are well tolerated by aortic regurgitation lesion, but to mitral regurgitation, it can create problems. Okay. Now that's one point. Second, what is the second point?
Sir, stroke volume increases, sir, with exercise.
No, exercise is right. What are the other reasons why aortic regurgitation is better tolerated than mitral regurgitation?
Sir, in mitral regurgitation, there is increase in pulmonary venous pressure because half of the forward stroke volume is into the left atrium, sir. Okay. So the pulmonary venous pressure they get higher relatively earlier than aortic regurgitation.
Very good. So because of the regurgitation takes place into the left atrium, the pulmonary venous pressure can go up. And at an earlier phase, the pulmonary venous pressure can go up and the patient can develop symptom of breathlessness. Very good. Yes. Okay.
Sir, compared to mitral regurgitation, aortic regurgitation develops the preload reserve is maintained for a prolonged period compared to mitral regurgitation, sir. Afterload mismatch develops at a very later phase in aortic regurgitation compared to mitral regurgitation.
That may not be a very important point. Yes, I agree with you that probably the mismatch occurs earlier in mitral regurgitation, but that's not a very important point. But one important point is that patients with mitral regurgitation has got the risk of developing an arrhythmia.
Arrhythmia, okay.
Which one?
Atrial fibrillation.
Atrial fibrillation. They can develop atrial fibrillation, and atrial fibrillation is a very late or, if at all, very unusual complication of aortic regurgitation. So patients with aortic regurgitation very rarely develop atrial fibrillation, but mitral regurgitation patients can develop atrial fibrillation quite early in life, quite early in the course of events of the. So because of these reasons, aortic regurgitation is much better tolerated than mitral regurgitation. Okay. Right.
Yes.
In this patient, what do you think? Is it mitral? You have got a clue that somebody whose external noise is coming. Can you please mute yourself? Can you please mute yourself? Yes. So in a patient with mitral regurgitation, obviously, now in this patient, do you think that aortic regurgitation is more likely or mitral regurgitation is more likely?
Aortic regurgitation.
Why do you say that aortic regurgitation is more likely?
So the palpitation is followed by dyspnea, sir, and he has a relatively long, relatively asymptomatic for nearly 10 years, sir.
Okay.
Initially it was exertional, then it has palpitation at rest also, followed by exertional dyspnea, sir. Mitral regurgitation develops relatively 5 to 10 years earlier than aortic regurgitation, sir.
See, there are two, 3 points. One is, see, in this patient, actually the patient has started developing exertional breathlessness.
Yes, sir.
The development of exertional breathlessness I will consider as a point more in favor of mitral regurgitation.
Okay.
But at the same time, for the past 10 years, patient is having palpitation, but he has not developed, from the story at least, he has not developed atrial fibrillation.
Okay.
That is the point more in favor of aortic regurgitation.
Okay, sir.
Then he is having an arrhythmia with a palpitation, which may be a fast palpitation, and that makes you start thinking that whether the patient is having an atrial arrhythmia. Could be even atrial tachycardia.
Yes, sir. Atrial tachycardia also possible.
May not be supraventricular reentry tachycardia. It can be even atrial tachycardia. And in that case, the possibility of mitral regurgitation becomes more likely in this patient.
Okay.
At the same time, there are some clues which are in the story that there is no history of
PND.
exposure to venereal disease, and there is no history of spine abnormalities. What is our relevance of spine abnormality?
Sir, connective tissue disorders like Marfan syndrome, Loyce-Dietz syndrome, bicuspid aortic valve, straight back syndrome, they usually have associated spinal abnormalities, which predispose to aortopathy, ascending aortopathy.
Kyphoscoliosis and all can happen with these abnormalities. Very good. And also, ankylosing spondylitis is associated with
Yes, sir, aortic regurgitation.
Aortic regurgitation. Severe aortic regurgitation can happen in patients with ankylosing spondylitis. And there is no history of exposure to venereal disease. Also indicates that the person who took the story suspecting that the patient may be having aortic
syphilitic lutic arthritis.
You want to know that, so there is a possibility of aortic regurgitation is in the mind of the person who has taken the story.
Yes, sir.
So, okay, can the patients with aortic regurgitation develop angina symptoms?
Yes, sir. Aortic regurgitation, they can develop angina, sir.
And what is the classical angina that can happen in aortic regurgitation?
Sir, it is classically described as nocturnal angina, sir.
Okay, nocturnal angina. Can you explain why patients with aortic regurgitation can have nocturnal angina?
Sir, there are 4 factors, sir.
Okay.
One is during night, there will be parasympathetic overactivity, sir.
Oh.
So during, they will have bradycardia, sir. And during bradycardia, the diastolic filling will be increased and the amount of regurgitant volume will increase, sir.
Very good.
Number 1, sir.
Okay.
Next is the aortic diastolic, the coronary perfusion pressure will come down because of the high LV and diastolic pressure, sir.
And also because of the prolonged diastolic phase, LV, aortic diastolic pressure comes down. Yes. At the same time, because of the continued regurgitation to the LV and diastolic pressure goes. So coronary perfusion pressure comes down. Okay, right? Yes.
Next, the severe aortic regurgitation, while lying down, they can produce a coronary suck effect, sir. They can suck during the regurgitant the regurgitant lesion itself can suck the blood from the coronaries and can produce ischemia, sir.
Okay, so in severe aortic regurgitation, during diastolic phase, there can be sucking effect on the coronary circulation, and that can interfere with the proper coronary filling. Okay, right? Yes. What else?
And because of the increased LV end diastolic pressure, the wall stress can increase, sir. So
Okay.
increased wall stress can predispose to subendocardial ischemia and they can cause angina.
Especially there can be increase in the diastolic volume can result in increase in the wall stress, and that can give rise to subendocardial ischemia. Okay. Anything which reduces the ischemia?
No, sir. I don't know, sir.
What happens when the heart rate is coming down? You said parasympathetic activity, heart rate comes down. When the heart rate comes down, what happens to the myocardial oxygen demand?
It will come down, sir.
It will come down. So actually, there are a number of factors, out of which most of the factors increase the myocardial oxygen demand or supply comes down. While one, especially decrease in the heart rate, can significantly reduce the myocardial
oxygen demand.
So ultimately, the effect of ischemia or the ischemia is based on which of these two which of these parameters are dominant. So in patients with aortic regurgitation, they can have nocturnal angina, and nocturnal angina is usually most often it is associated with levitic aortic regurgitation than other forms of aortic regurgitation. So nocturnal angina. Okay, what do you mean by paroxysmal nocturnal dyspnea? Hello?
Yes, sir. Paroxysmal nocturnal dyspnea. As a patient goes in for.
Kapil, is the noise coming from your?
Yes, sir. I have muted, sir. Sorry, sir.
No, don't mute. If you mute, you cannot talk.
Yes, sir. Yes, sir. This is child, sir. Sorry, sir.
You can take. It's your child. So.
Sorry, sir. Sir, paroxysmal nocturnal dyspnea. As a patient goes in for sleep, after 2 to 3 hours of sleep, the patient gasps for a breath and then rises up during sleep and comes to a upright position, sir. And dyspnea is relieved after receiving recombinant position, sir. Particularly, it occurs after 2 to 3 hours after sleep, sir.
Are you worried when somebody is having paroxysmal nocturnal dyspnea? Are you really worried?
Yes, sir.
Why?
Sir, it indicates a predominant left-sided disease, sir.
When indicates
heart disease.
What else? So, in case left-sided disease, why should you be worrying?
So, in the functional, it is a functional class 3. Paroxysmal nocturnal dyspnea is considered a near functional.
No, paroxysmal dyspnea, actual nocturnal dyspnea, according to New York Heart Association classification, you cannot classically put anywhere because it does not really come out. But it is better to put that you can explain the patient is having class 2 symptoms and also having paroxysmal nocturnal dyspnea. Put it as a separate one. Paroxysmal nocturnal dyspnea does not come under the classical description of the paroxysmal of the NYHA classification. So you can classify the patient NYHA class 2 plus paroxysmal nocturnal dyspnea.
Okay.
So paroxysmal nocturnal dyspnea is why are you so much worried about paroxysmal nocturnal dyspnea?
Sir, it signifies capillary wedge pressure is RJM.
Okay. What is the reason for anxiety when somebody is having paroxysmal nocturnal dyspnea? That is because most of the times, as Kapil has rightly pointed out, patients who wake up after 2 to 3 hours or 1 to 3 hours of sleep, sits up for some time, and the patient gets better, the breathlessness comes down, and he goes back to sleep. And he does not get any more episodes of paroxysmal nocturnal dyspnea. While some of the patients, very few patients, maybe very small percentage, can progressively develop breathlessness, can become more and more, even develop pulmonary edema, and sometimes even may end up in a fatal outcome. So paroxysmal nocturnal dyspnea is a very serious symptom. A small percentage can actually progress to higher grades of breathlessness, including a pulmonary edema and rarely even a fatal outcome. So paroxysmal nocturnal dyspnea is a very major symptom. So paroxysmal nocturnal dyspnea very often, most of the times, as you rightly said, it occurs The patient sits up, gets a relief, and goes back to sleep, and he does not get any more episodes of paroxysmal nocturnal dyspnea. What is the reason that he is not getting any more episodes of breathlessness? Can you explain it? Most of the time, patients who get better by sitting up, they go back to sleep. Rest of the night they sleep very well and they don't get any episodes of breathlessness at night. What is the mechanism why paroxysmal nocturnal dyspnea at night once it is relieved does not recur? Kabin?
Sir, no, sir. No, sir, I'm not sure, sir.
Any one of you, anybody who is in the among the students, can you tell me why is it that patients with paroxysmal nocturnal dyspnea most of the times occurs only one episode and then it does not recur? Kapil, can you tell me the mechanism of PND?
Sir, paroxysmal, it's mainly due to redistribution of the interstitial fluid into the intravascular compartment, sir.
Okay, the extravascular compartment fluid gets into the intravascular compartment. Yes, mostly at the from the legs, dependent
Yes,
parts of the body. Mostly from the lower limbs. Okay, yes.
So a stimulation of juxtacapillary J receptors around the
Okay.
lung interstitial.
Now, this is the main mechanism. So at night, when the patient has developed paroxysmal nocturnal dyspnea, what are the mechanisms by which the paroxysmal nocturnal dyspnea is relieved?
So by sitting up, sir.
On sitting up. So sitting up alone is not enough because he has got a volume overload. So something more should happen.
So by
Because of the fluid reabsorption, the volume in intravascular space goes up, and that can result in some degree of diuretic effect.
okay.
And some urine can be passed, and the patient gets immediate relief. And when the patient goes back to sleep, is the patient having any more extravascular volume? We said it is the fluid from the extravascular space getting absorbed into intravascular space. So that has happened. And once the patient is relieved and is going back to sleep, is there any extravascular volume to be reabsorbed further into intravascular space?
No, sir.
No, let's say whatever is the fluid was available in the extravascular space is already absorbed into intravascular space. So once the patient gets the relief and he goes back to sleep, there is no more fluid in the extravascular space to be absorbed and he does not get any more episodes of paroxysmal nocturnal dyspnea. So paroxysmal nocturnal dyspnea is one symptom, or just once. And if the patient gets the relief, he goes back to sleep and there is no more episodes. This relief may be partly related to perspiration or maybe related to some amount of diuretic effect, so that whatever is the extra volume of blood which has come to the left side or which has created the paroxysmal nocturnal dyspnea is excreted by the body. And since there is no more extravascular space, then there is no more extravascular fluid to be reabsorbed into the intravascular space, there is no more episodes of breathlessness at night. So paroxysmal nocturnal dyspnea most often occurs only once, and once the patient gets relief, he goes back to sleep, he does not get any more episodes. Okay, so when a patient comes and he's having paroxysmal nocturnal dyspnea, and he is under your treatment, and about 2 weeks later, he comes and tells you that my paroxysmal nocturnal dyspnea is no more, I'm able to sleep very well. What are the interpretations? What are the things that you will carefully look for? Or what are the mechanisms by which a paroxysmal nocturnal dyspnea can disappear?
Sir, development of pulmonary hypertension, sir.
Yes, don't use the word pulmonary hypertension. Development of right heart failure. Or a right heart lesion. For example, a patient with severe tricuspid stenosis is having associated mitral stenosis. When the tricuspid stenosis becomes significant, the symptom of paroxysmal nocturnal dyspnea due to mitral stenosis can disappear.
Yes, sir.
So the right-sided heart failure or right-sided lesion can actually alleviate the paroxysmal nocturnal dyspnea. So when you find that a patient has come and told you that his paroxysmal nocturnal dyspnea has come down, it has disappeared, it can be due to two reasons. One, your treatment is effective and his LV function has improved, and that may be the most likely possibility. Second possibility is that patient might have developed associated right heart failure resulting in disappearance or alleviation of the pulmonary congestion, and hence no more episodes of paroxysmal nocturnal dyspnea. So one of these two can result in alleviation of the paroxysmal nocturnal dyspnea when a patient says that. So whenever a patient says that he is relieved of paroxysmal nocturnal dyspnea, you should carefully examine the patient whether he has developed right heart failure or not. Okay. So these are the few points that we can discuss from the story part. Anybody who would like to raise any point or any doubt, so that we can go to the physical findings. Any point that anybody would like to discuss?
Sir, doubt, sir.
Oh, yes. Please.
Sir, aortic regurgitation, it is
Aortic regurgitation?
Regurgitation.
has the largest volume of left ventricle compared to other regurgitations.
Yeah. Usually, because the regurgitation is taking place into the ventricle, and hence they will have a much larger LV volume. Okay. Any other doubt? Anybody would like to clarify any point? Okay. So we'll go to physical findings. Okay. Right. Yes.
On examination, patient is well built, comfortable, not dyspneic, height 172 centimeters, weight 68 kg, arm span 170 centimeter, no pallor, no cyanosis or clubbing, no edema of dependent parts. Cardiovascular system examination, the pulse rate is 70 per minute, regular, high volume, collapsing, SL wall not felt, all peripheral pulses are felt, no radial or radiofemoral delay. The blood pressure in the right upper limb and left upper limb is 140 by 40, and right lower limb is 190 millimeter systolic. Jugular venous pressure is not elevated, normal wave pattern.
What is meant by 140/40-0?
Sir, the diastolic, the correct sound is heard. Muffling is at 40, sir.
Okay.
And we are hearing it.
But you can continue to hear the sound till 0. Can at any time the diastolic pressure in the blood vessel be 0?
Sir. We are hearing it till 0, sir, but the actual muffling is taken as the diastolic pressure.
Yeah. So his diastolic pressure is 40. That's right. But when I am asking you a question, can at any time
No, sir.
the aortic pressure diastolic pressure can be 0?
No, sir.
Now why?
The actual intra-arterial blood pressure, what we are measuring is not the exact pressure we are seeing through the sphygmomanometer, sir.
Okay.
It can never be 0, sir.
Why? You have to tell me hemodynamically why it cannot be 0.
The aortic valve will close if the diastolic blood pressure becomes 0. Sir.
Aortic valve will close
No, sir. No, sir.
or open.
Oh, sir. Sir, open, sir. Open, sir.
Okay.
Open, sir.
When there is an aortic regurgitation, what will happen to LV and diastolic pressure?
Sir, it will increase.
It will go.
Can increase, or it may be 8, 10, 11, 12. So whenever the aortic pressure falls below the LV and diastolic pressure, what will happen to the aortic valve?
It will open, sir.
It will open. So you cannot get a 0
It won't close, sir.
at all. Even if you are hearing the sound till 0, the diastolic pressure cannot be 0, because when the diastolic pressure in the aorta falls below that of the LV diastolic pressure, the aortic valve opens and the blood will flow from the LV to the aorta. So you can never get a 0 diastolic pressure in the aorta. So the pressure in the will be 0. Okay. So in the pressure data, what is your interpretation?
Sir,
It is consistent with what lesion?
Sir?
It is consistent with what lesion? Is it a more like aortic regurgitation or mitral
It's
regurgitation?
aortic regurgitation.
Okay, what are the points for you to say that this could be aortic regurgitation?
Sir, the pulse pressure is 100, sir.
Very good.
And the upper limb, lower limb difference is 50, sir.
50. What is the normal upper limit, and then what is your interpretation?
So normally it is up to 20, sir.
Up to 10, up to 10. 10 to 20 is borderline.
Yes, sir.
It is intermediate. You are not certain. Up to 10 is the usual. 10 to 20 can still be passed off as normal. Okay, right. Yes. More than 20?
More than 20, up to 40 is grade 1, sir, hillside.
Okay.
40 to 60 is grade 2, sir. More than 60 is grade 3, sir.
Okay. So here the difference is 50. So at least moderate positive hillside. Okay. Very good. Okay, right. Yes. Now coming to the pre-cordial examination.
Last year,
Yes.
Someone is talking in the middle, sir. Cross-talk is.
Now, are you somebody is talking in between? Is there a doubt, or you are talking to somebody else? Whenever somebody is talking, it is better that all others unmute yourself, mute yourself, so that there is no disturbance. And whenever you have got a doubt, you can unmute and ask a question.
Someone with XT
Someone is talking, sir. Someone is talking. Sir.
This XT name, with someone with XT name is having this mic open.
So somebody
I am present. I am present. That is my name.
இல்ல உங்களுக்கு அலர்ட் ஒண்ணு கிடைக்குது அது மட்டும்
all others can, if other than Kapil, if all others can mute yourself, I think there will not be any disturbance. And then if you want to ask a question, you
போட்டுருச்சு அதான் இப்போ ரெண்டு போலாமா சிங்கிள் இது போல சிங்கிள் லேயர் ஏன்னா பிபி கொஞ்சம் நடுவில் கீழே கிராஸ்
beg your pardon?
இன்னைக்கு பார்த்து நாளைக்கு பிபி பார்த்துட்டு போடுறேன் சார் இன்னைக்கு அலர்ட் மட்டும் போதும் நாளைக்கு மார்னிங் பிபி
Someone is talking through.
Somebody is talking through the
Unmuted.
Zoom, so that it disturbs our teaching program. I think you should not disturb others.
I think, sir, this Sun Mukkam somebody.
Sain, can you identify the person who is creating disturbance? Sain, are you there?
Sir, now it is muted, sir.
Okay, right.
Now
Go ahead. Okay, right. Yes.
Inspection and palpation, sir. Sir,
Apex beat.
Sir, the apex beat is seen and felt in the sixth left intercostal space 1 centimeter outside the midclavicular line. Forceful, no thrills or sounds palpable, no parasternal lift, no sounds or thrill felt in the base of the heart. Suprasternal pulsations are seen and felt. Carotid pulsations are seen. Abdominal aortic pulsations are felt in the epigastrium.
Okay. Interpretation.
Sir, because of the wide pulse pressure, first the apex beat is shifted to down and out, sir.
Okay, very good.
Because of this, there is cardiomegaly, sir.
Okay.
Next,
What type? LV type or RV type or biventricular?
sir, it looks like left ventricular type of cardiomegaly, sir.
Left one. How will you differentiate between LV type, RV type, and biventricular type?
Sir, left ventricular type of cardiomegaly will be they will have a down and out outward shift, sir.
Okay.
And it will be expansile apical impulse, sir. RV type will be
what do you mean by expansile? Say apical impulse has got only 3 characters, or rather 4: normal, tapping, hyperdynamic or forceful, and heaving. So you cannot you cannot use the word expansile and all.
okay, sir.
You have to stick to these terms only. So say that either tapping, normal, forceful, or hyperdynamic. Rather stick to forceful and heaving apex. So there is no more confusion. When you use the word expansile, then the examiner will ask you what do you mean by expansile. There is no description like that. So where did you get this term from?
Okay, sir. And it will be more of a forceful apical impulse, sir.
Yeah, this is a forceful apical impulse. Yes.
Yes, sir. RV type of apical impulse will be.
No, RV also can be forceful. No,
sir. I'm LV, sir. I'm telling LV only, sir.
No, RV also can have forceful apex beat. So that is not a differentiating point. You have to tell me the differentiating point why you are saying it's LV.
Down and out shift, sir.
That's there. Great.
Sustained lift, sir. Occupying more than 2/3 of the systole.
No, then it becomes heaving.
Yes, sir.
It's a forceful apex beat. So here, the character is not the one which decides whether it is LV type or RV type. Where is the right ventricle situated? Is it at the region of the apex pit or at the region of the parasternal region?
Parasternal region.
Parasternal region. In this patient, is there a parasternal lift?
There is no parasternal lift, sir.
No parasternal lift. The apex pit is localized, 6 intercostal space, down and out. So it is an LV impulse, and there is no indication of an RV involvement in this patient.
Yes, sir.
What will be the feature of biventricular involvement? How will you make out whether the patient is having both LV as well as RV?
So there will be a parasternal lift, sir.
Yeah, there will be a parasternal. You palpate the apex pit and you try to move medially. As you move medially, the apex pit, the cardiac impulse comes down. It comes down significantly, and then as you reach the parasternal region, there will be further impulse again. Yeah, that is so. First impulse is the apical impulse is due to LV, and the parasternal region you get the RV impulse. So you get two impulses. One, LV impulse, which is forceful or heaving, whatever it is. Then you get an area where there is no significant impulses or impulse significantly comes down. And then you get again a prominent impulse in the parasternal region, like in the parasternal lift. So obviously there is both right and left ventricle involvement. Right. How will you make out whether it is the apex is formed by the right ventricle?
Sir, in right ventricle there will be inward retraction, sir.
Okay, very good. You can always look for inward retraction, and more importantly, you can try to trace from the apical impulse to the parasternal region. When you try to trace from the apical region to the parasternal region, there is no break in between, and also the impulse is becoming more and more prominent as you reach the parasternal region. Then you can conclude that probably the apex is formed by the right ventricle. I will repeat: the impulse is tracked from the apical region to the parasternal region. In between, there is no reduction in the apical impulse, or rather no reduction in the cardiac impulse. The impulse remains the same or gradually increases in its activity, and finally at the parasternal region, he has got a very prominent cardiac impulse that is highly suggestive of RV forming the apex. So so I will repeat: if the apex beat is localized, and as you trace medially, there is no the cardiac impulse quickly dies down, and there is no cardiac impulse in the parasternal region. It indicates purely LV enlargement, and the apex is formed by LV. Two, you get the impulse of the apical region. As you track medially, the impulse comes down. There is an area where the impulse is very insignificant, and as you reach the parasternal region, you get prominent parasternal lift. That is suggestive of biventricular involvement. You get an apical impulse which can be diffuse, mostly diffuse, not localized, and sometimes it can be forceful also. As you track medially, the impulse continues to increase in its activity. There is no reduction in the activity of the impulse. Impulse gradually becomes more and more prominent, and in the parasternal region, there is significant parasternal lift. At that patient, most likely the apex is formed by the right ventricle. And this is the situation where in a patient with adult ASD, you may get a apical impulse which is formed by the right ventricle. So you have to be very careful. In a patient with ASD, if there is an adult ASD, most often it will be kept in the examination, and the apex is formed by the right ventricle. And as you track medially, the impulse actually becomes more and more prominent. And in the parasternal region, really you have got a very prominent impulse, and that is very suggestive of apex is being formed by the right ventricle. So you can, by palpating very carefully, you can make out whether it is only an LV or whether it is LV plus RV or whether it is an RV. Okay, are you clear, Kabir?
Yes, sir. Yes, sir. Yes, sir. I'm clear, sir.
Okay, right. Yes. So here it becomes more of an LV type, and also there is evidence that there are prominent aortic pulsations because abdominal aortic pulsations are felt in the epigastrium.
Yes, sir.
Okay, right. So go ahead. Percussion.
Percussion left quarter corresponds to apex beat, sir. Second intercostal space on either side is normal resonance. Right heart quarter dullness does not extend beyond the right sternal border.
Okay, very good. So obviously there is no enlargement of the heart to the right side, especially right atrium is not enlarged. That is the conclusion that we can draw from the percussion findings. Okay, right? Yes.
Auscultation. First heart sound is feeble, sir. Heard all over the precordium. Best audible at the apex. Second heart sound is single, normal intensity. Best heard at pulmonary area. Heard in the aortic area also. No S3, S4 or no ejection clicks.
Okay.
Murmurs. Early diastolic blowing, high pitched, best audible in the third left intercostal space close to the sternum and heard down along the left sternal border. Best heard with patient sitting up, leaning forward and breath held in expiration. Grade is 2/6, sir. Mid-diastolic rumbling, low-pitched murmur at the apex with no presystolic accentuation and no change with breathing. A mid-systolic, harsh, early peaking murmur, best audible in the aortic area and expiration and conducted to the carotids, the grade 3/6. Early systolic, flowing, high-pitched murmur at the apex, no conduction, no change with breathing, best heard in left lateral position, grade 2/6. Peripheral signs of aortic runoff, a collapsing pulse is present, distal short sound is heard, derisive murmur is heard, capillary pulsations are felt at the fingertips, and no evidence of heart failure.
Okay, take one after another auscultation. S1 feeble. What are the conditions in which you can get? Enumerate the conditions you can get feeble S1.
Sir, mitral regurgitation.
Mitral regurgitation. Okay, right. Yes.
Aortic regurgitation, sir.
Aortic regurgitation. Very good.
Bradycardia.
Bradycardia. Why should there be a feeble S1? What are the situations where you can get feeble S1? Anybody else who would like to? Feeble S1.
Severe LV dysfunction, sir.
Okay, severe LV dysfunction, very good. In severe LV dysfunction, you can get a feeble S1, very good, yes.
Calcific aortic stenosis.
By calcific aortic stenosis, there can be S1 feeble.
Severely calcific, sir.
There can be, if there is an associated some degree of LV dysfunction, yes. Because otherwise, why should the
calcified mitral valves? Calcified mitral valves.
Yes, calcified mitral valve. Very good. If the mitral valve is calcified, especially there is a dense calcification, the S1 can become feeble. Yes. What else? Anything to do with PR interval?
Sir, wide, long PR interval, sir.
Long PR interval.
Yeah, long PR interval is also associated with
soft S1, sir.
Soft S1. Okay. Right. Can you tell me at what phase of the PR prolongation you get the soft S1, and what phase you get the loud S1, and at what phase you get the normal sound again?
Sir, 120 to 200 milliseconds of PR interval, the S1 will be normal, sir.
Okay, very good. Yes.
200 to 240, the S1 will, the intensity will come down, sir.
Not up to 240. Beyond that even. About 340, not 240, 340. The sound can actually come down, and then it will again get back to normalcy, normal sound.
Yes, sir.
What is the mechanism?
Sir, so at more than 360 milliseconds, the reason why the S1 becomes normal is the LV end-diastolic volume will increase, sir, and there will be increased post-systolic potentiation. There will be potentiation, and the first heart sound intensity will become normal, sir. And with
in a prolonged PR interval, why the S1 is feeble?
Sir, the dP by dt will be less, sir. The rate of the rise of
why should the dP by dP? I agree with you that the dP or dt will be best when the LV contracts immediately at the end of the aortic LV LA contraction, where the emptying of the blood into the LV has taken place. But what the most important reason why the PR is prolonged, resulting in a feeble S1, is because of?
Sir, the mitral valves will move to a more closed position even before the onset of systole, sir.
Why it is so?
Sir, the LV and diastolic volume will increase, sir. Prolonged PR interval will improve the diastolic filling, sir, and it will push the mitral valves.
It may not increase. Why should the prolonged PR interval increase the? What are the phases of ventricular filling?
Sir, first one is early rapid filling.
Okay.
Diastasis. Okay. Then third is the atrial kick, sir.
Right, very good. After the atrial contraction, which has taken place, there is a prolonged PR interval. Why should there be further filling of the LV? After the atrial contraction, what happens to the atrium?
Atrium will, there will be isovolumetric relaxation, sir.
No. What will happen to the atrium? Our atrium is contracted, emptied its contents to LV. Then what will happen to the atrium? The atrium will remain contracting or it will relax?
It will relax, sir.
It will relax. When it relaxes, what happens to the atrial pressure?
It will come down, sir.
It will come down. Then what will happen to the mitral valve and what will happen to the LV filling?
LV filling will come down, sir.
LV filling, actually there won't be any LV.
There won't be.
And actually the mitral valve will float back because when the LA dilates, the LA pressure can come below that of the LV pressure. And the mitral valve leaflets floats back and resulting in a semi-closed position. And when the LV contracts, the movement of the mitral valve is over a short range and that will result in a feeble S1.
Yes, sir.
Are you getting the point? I'll repeat.
Yes, sir. Yes, sir. Understood. Yes, sir.
Whenever after the LA contraction, the most ideal thing is immediately LV should contract. If there is a PR prolongation, after the LA contraction, when the LA starts dilating, the LV has not yet started contracting. When the LA starts dilating or relaxing, that will result in a lowering of the LA pressure. The LV pressure remains the same, but since the LA pressure is lowering, the mitral valve leaflets will float back and will come to a semi-closed position. And when the LV contracts and causes the mitral valve to close, it moves over a short range and that will result in a feeble S1.
Yes, sir.
After the 320-340 seconds, why the first sound becomes normal again?
No, sir. I don't know, sir.
What will happen when the left atrium relaxes?
The LA pressure will come down, sir.
LA pressure transiently comes down. So what is the hemodynamic change? What will happen to the venous drainage to left atrium?
Venous drainage will gradually increase, sir.
Not gradually, suddenly increase because there is a sucking effect of the LA dilatation through the pulmonary veins, and there is a quick flow of blood from the pulmonary veins. And when the pulmonary veins rapidly empty into left atrium, what will happen to left atrial pressure?
LA pressure will increase, sir.
Increase. Then what will happen to mitral valve or mitral valve leaflets?
It will move widely apart, sir.
Yes, it will move open again. And so, if when the PR prolongation occurs, because of the venous drainage into the left atrium pressure goes up, and that will further again push open the mitral valve, and the leaflets will go back into the original opening position.
Yes, sir.
Do you understand?
Yes, sir. Can you please repeat once, please?
Okay, I will repeat. So, up to 120 milliseconds, there will be an increase in the first sound. PR interval up to 120 S1 will be loud. That is because when the left atrium is contracting, the mitral leaflets are fully open, and even before the left atrium finished its contraction, the LV starts contracting, resulting in a longer range movement of the mitral leaflets, resulting in a loud S1.
Okay, sir.
Is it clear?
Yes, sir.
Second is a normal phase in which the LV fills because of the atrial contraction, and at the end of the atrial contraction, just as the atrium starts relaxing, the LV contracts, resulting in the normal S1.
Yes, sir.
When the PR prolongation occurs, what happens? When the PR is prolonged, the left atrium starts dilating, the left atrium is relaxing, left atrial pressure comes down, the mitral leaflets float back, and that will result in, when the LV contracts, that will result in a feeble S1. Then, when the LA starts relaxing, there is a sucking effect on the pulmonary veins, and the blood drains from the pulmonary veins into the left atrium. This will result in elevation of the left atrial pressure. As soon as the left atrial pressure gets elevated, it pushes open the mitral valve again, and the mitral leaflet goes into a much more open position. And when the LV contracts at that time, the first sound will be normal. So when the PR is prolonged beyond around 320, 340, the first sound can again become normal. It is because of the filling of the left atrium, the left atrial pressure goes up, it pushes the mitral valve open again, and from this position of open mitral valve, when the mitral valve closes, it can give rise to normal S1. So very short PR interval, S1 is loud. Then normal PR interval, S1 is normal. And then the PR is prolonged from 200 to around 320 milliseconds, the S1 is feeble. And beyond 320, 340, the S1 again becomes normal. Is that clear to you, Kamil?
Yes, sir. Yes, sir. Very clear, sir.
So here the S1 is feeble. So you have mentioned a few conditions. Can you think of any condition whenever you are hearing a mitral regurgitation and loud S1? What is your interpretation?
Sir, it could be mitral valve prolapse, sir.
Very good. It could be mitral. What is the mechanism?
Sir, it is due to sudden excursion of the prolapsing mitral leaflet into the LA, sir.
Very good.
Producing a snapping sound, sir.
Yeah.
Next thing, actually, it is the intensity of the click which we are hearing as loud S1, sir.
Very good. It's actually in pan-systolic mitral valve prolapse, you get loud S1, where the sudden prolapse or the sudden prolapsing of the diseased valve leaflet into the left atrium results in a snapping noise, which actually is the non-ejection click, which sits on the first sound. They occur almost together, and that will result in a very loud S1. So whenever you are hearing a loud S1 in a patient with mitral regurgitation, always think of the possibility of pan-systolic mitral regurgitation. That's one reason. Second mechanism. Sometimes in patients with mitral stenosis, mitral regurgitation, you can get a loud S1 because of the effect of mitral stenosis, and the patient can have rheumatic mitral regurgitation. So in a patient with rheumatic mitral regurgitation, when you hear a loud S1, always think of the possibility of associated mitral stenosis. Second, you can always think that it could be due to the pan-systolic mitral prolapse, which results in non-ejection click sitting on the first sound, giving rise to a snappy first sound. Okay, yes. So here this one is feeble. Now this patient is having a single S2. What is your interpretation?
Single S2. Sir, there could be associated pulmonary hypertension. The pulmonary venous pressures could be high, sir.
But it is written normal in intensity, S2 single normal in intensity.
So the LV ejection is very fast, very rapid, sir. So
Okay,
it could be single S2.
No.
Sir, single S2 can
is rapid, then it will give rise to single S2 or a wide S2.
Sir, this single S2 could be a late A2 or an early P2, sir.
Okay.
Two possibilities are there, sir.
Yes.
Here, this single S2 could be possible due to associated aortic stenosis also, sir. Producing
You think that there can be associated aortic stenosis, and that is why the S2 is single.
That is one possibility, sir.
Okay, right, yes. So that we'll have to come to discussion on the murmurs. But
Yes, sir.
what is the usual pattern of S2 in aortic regurgitation?
Sir, usually the intensity will be normal to soft, sir.
Okay. Or it can sometimes be loud also, because depending upon whether the cause of aortic regurgitation is due to an aortic root dilatation. Sometimes the closure A2 can resonate on the dilated aorta, and sometimes it can be loud. So that is still possible. But my question is that can the aortic regurgitation itself can explain S2 single?
So it could dilated aortic root, dilated aorta producing a single prominent A2 alone, sir. Could be a loud A2 alone.
So loud, or you are thinking that you are hearing only the A2 and you are not hearing the S2? No.
Yes, sir.
You have to give an explanation why you are not hearing P2.
So, because of aortic regurgitation, the ascending aorta root could be dilated, and it could dilated aortic root could be very anterior and suppressing the second P2.
Why should the aorta be anterior? Normally, next question is anterior. Is the aorta is anterior or pulmonary artery is anterior?
Pulmonary artery.
Pulmonary artery is anterior. Okay.
Yes, sir.
In a patient with aortic regurgitation, can any one of you explain that in a patient with aortic regurgitation, can there be paradoxical splitting? Any one of you? Would you like to give explanation? Any one of you would like to give an explanation?
Sir, because of aortic regurgitation, there is more end diastolic volume is there, so there will be more time is required to push the blood out. So the S2 will be delayed, sir.
That is not the correct explanation, because actually the LV is able to pump the blood out very quickly because of the reduced
Increase in the aortic hangout intervals. Aortic hangout interval will increase.
Yes, there is because of the reduced peripheral resistance that will result in increased aortic hangout interval.
Yes, sir.
The hangout interval depending upon the resistance to which the LV is pumping the blood. For example, normally the systemic resistance is much more than the pulmonary vascular resistance, and because of that, the hangout interval of the pulmonary valve is much more than that of the aortic valve, and hence you get a late P2. While in a patient with aortic regurgitation, what happens to the peripheral resistance?
So the peripheral vascular resistance will be low, sir.
It will be low. When the peripheral vascular resistance becomes low, what will happen to the A2?
Sir, the A2 will be delayed, sir. Closure of A2 will be delayed, yes, sir.
There can be a delayed closure, and in very severe aortic regurgitation, sometimes you will be able to appreciate even a classical paradoxical splitting. But very often it won't be that much, and very often what you get is actually a single S2. So single S2 in aortic regurgitation can be explained by saying that it can be due to delayed A2, secondary to prolonged hangout interval, resulting in A2 and P2 occurring almost together and resulting in a single S2. So this can be a feature of aortic regurgitation, especially this patient's blood pressure is 140 or 40/0, so meaning that there is a significant reduction in the peripheral resistance.
Yes, sir.
Okay, that can be explained. Okay, now coming to the murmurs.
So murmurs, the first murmur is early diastolic blowing, high-pitched murmur.
Okay. What are the cause of early diastolic murmur?
So first is aortic regurgitation, sir.
Aortic regurgitation.
Pulmonary regurgitation.
Pulmonary regurgitation. Any other?
Sir, Austin film murmur.
Austin film murmur is not a early
diastolic. Sir, mid-diastolic.
Truncal regurgitation, sir.
Truncal regurgitation. Very good. Truncal regurgitation.
Proximal LAD stenosis also, sir.
Yes, yes. And LAD stenosis also. What is the name of that murmur?
Dox murmur.
Dox murmur. Yes. So we described, but I am not fully convinced. But three differently you should mention: aortic regurgitation, pulmonary regurgitation, and truncal regurgitation. And if the examiner asks for, do you know any other murmur? Then you can say that in patients with proximal LAD stenosis, early diastolic murmur has been described by a gentleman by name Dr. Dock, and that is known as Dock's murmur. D-O-C-K, Dock's murmur. Okay, right, yes. So here he has got early diastolic murmur. And what do you think is the reason? Is it truncal regurgitation, aortic regurgitation, pulmonary regurgitation? What is the reason?
Sir, to be aortic regurgitation.
Plenty of peripheral signs, everything is there. So all put together it is and early diastolic murmur is aortic regurgitation is much more frequent than all other causes. So whenever you are hearing an early diastolic blowing high-pitched murmur, especially in the aortic area and parasternal region, always go for aortic regurgitation. Okay, right. Yes. So it's due to aortic regurgitation. Okay, next murmur.
So mid-diastolic rumbling, low-pitched murmur at the apex, sir.
Okay.
No presystolic accentuation and no change with breathing, sir.
Okay, what do you think it is due to?
Sir, it could be two possibilities, sir.
Oh.
One could be Austin Flint murmur, sir. The second one, it could be flow murmur, sir. Flow mid-diastolic murmur at the mitral valve, sir.
Flow due to what? Oh, flow due to what?
Due to associated mitral regurgitation.
Oh, is there any evidence of a severe mitral regurgitation?
No, sir, there is no severe mitral regurgitation, sir. No, sir. Only first possibility is Austin Flynn murmur only, sir.
Okay.
There is no.
Why can't it be associated with mitral stenosis? How will you differentiate Austin Flynn murmur from mitral stenosis murmur? Before that, what is the mechanism of Austin Flynn murmur?
Sir, three mechanisms are described, sir.
Okay.
One is the regurgitant, aortic regurgitant jet impinging on the anterior mitral leaflet, opening anterior mitral leaflet of the mitral valve, sir. Second one.
No. What did you say? Please repeat.
Sir, the aortic regurgitant jet impinging on the mitral leaflet, sir. Second one is
resulting in what?
Resulting in functional mitral stenosis, sir.
Okay, it can partially close the mitral valve and can give rise to some degree of functional or a partial mitral valve. You're right. Yes. Second mechanism.
Second one is the turbulence produced by the regurgitant jet as well as the mitral flow, sir.
Okay. There are two jets are coming to the left ventricle. One is the regurgitant jet, other is the flow coming through the mitral valve, and that produces a big turbulence giving rise to mid-diastolic rumble. Very good. Third point.
Third one is the transmitted frequencies or low frequency vibrations being transmitted to the apex, sir, because of the aortic regurgitation. These are transmitted frequencies, sir.
But the aortic regurgitation is an early diastolic murmur.
These two only I know, sir.
Diastolic MR, sir.
Actually, when Austin Flynn initially described, actually it was a diastolic or mid-diastolic MR, which actually was the mechanism for Austin Flynn murmur. So a third mechanism you can say maybe due to a diastolic mitral regurgitation. And one more point you can say is that as the regurgitant jet comes and strikes the anterior mitral leaflet, what happens to anterior mitral leaflet?
There will be vibration of AMN, sir.
Yeah, there will be a fluttering movement of the AMN that also can give rise to mid-diastolic rumble. So there are four mechanisms. One, as you rightly said, as the jet comes and strikes the anterior mitral leaflet, it can cause a partial closure of the anterior mitral leaflet, resulting in relative mitral stenosis. Two, there are two jets coming into the LV, one coming from the aortic regurgitation, second coming from the mitral valve, that produces a turbulence giving rise to mid-diastolic rumble. And third, the regurgitant jet comes and strikes the anterior mitral leaflet, producing fluttering movements that can give rise to mid-diastolic rumble. And fourth, as rightly said, there can be associated diastolic mitral regurgitation, which can also contribute to the mid-diastolic and late diastolic murmur. So there are four mechanisms for the production of the Austin Flynn murmur. How will you differentiate whether it is Austin Flynn murmur or a murmur of mitral stenosis?
Sir, Austin Flynn murmur increases with the intensity of Austin Flynn murmur increases with isometric hand grip, sir.
Okay, by process which can actually increase the aortic regurgitation, the intensity or the clarity of the Austin Flynn murmur can increase. Very good point. Yes. Two.
Next is amyl nitrate. It is a historical, sir, but what is described is amyl nitrate inhalation increases the intensity of mitral stenosis mid-diastolic murmur, but decreases Austin Flynn murmur, sir.
What is the reason?
Sir, amyl nitrate actually causes peripheral vasodilatation, sir. Peripheral vascular resistance will come down, sir. So the intensity of aortic regurgitation and Austin Flynn murmur will come down, sir.
Very good.
But in mitral stenosis, there will be reflex tachycardia and increase in heart rate increases mid-diastolic murmur of mitral stenosis, sir.
Very good. But on the bedside clinical examination, you cannot give amyl nitrate inhalation. Not agree with you that amyl nitrate by increasing the heart rate can increase the mitral stenosis murmur.
Simple exercise.
The reduction in peripheral resistance can result in less of aortic regurgitation and less of Austin Flynn murmur. Okay, very good. Yes.
So simple exercise Just push sit-ups and simple exercise itself can increase the intensity of mitral stenosis murmur, sir. But Austin film murmur, since the peripheral vascular resistance comes down with exercise, sir, the intensity will come down, sir.
But bedside clinical examination, there are plenty of points for you to suspect. Why should you go for all these interventions?
Sir, next the intensity of S1 will be loud in mitral stenosis, sir. S1
Very
will
good.
be-
That's a very, very important point. If the S1 is loud, that is strongly goes in favor of mitral stenosis.
sir.
But the feeble S1 is more in favor of
Aortic regurgitation, sir.
Austin fin murmur. Okay, right.
Yes,
One point.
opening snap will be there, sir.
Second point.
Opening snap will be there, sir.
Opening snap. If there is an opening snap, that is strongly in favor of mitral stenosis. Okay, right. Third point.
Pre-systolic accentuation will be
Very
there
good.
in.
Excellent. Pre-systolic accentuation is a strong point in favor of, not strong point. If there is a pre-systolic accentuation, it is always mitral stenosis. So, pre-systolic accentuation is a point strongly in favor of associated mitral stenosis. Another point.
Sir, S3 will be there in aortic regurgitation, sir. S3.
In aortic regurgitation occurs when the patient has developed LV dysfunction. S3 in aortic regurgitation usually indicates LV dysfunction.
Sir, associated pulmonary hypertension and AF, sir.
Very good, excellent. Your associated complications like pulmonary arterial hypertension and atrial fibrillation goes more in favor of mitral stenosis. Very good, excellent. Any other point?
Three leaf present, sir, it suggests MS, sir. And the PND, also, history of
Very
PND.
good. Very good. If there's a thrill, that's more in favor of mitral stenosis. But thrill has been described in patients with Austin fin murmur also. So it should be mentioned as a slightly low in the list. So absence of a thrill is more in favor of Austin fin murmur. So the points by which you differentiate are S1. If it is feeble, more in favor of Austin fin murmur. 2. If there is a pre-systolic accentuation of the murmur, go more in favor of mitral stenosis. And loud S1 more in favor of mitral stenosis. Third point, if the patient is if there is associated complications like atrial fibrillation or the patient is having pulmonary arterial hypertension, that will strongly go in favor of mitral stenosis. If the patient is having a thrill at the apex, that will be strongly in favor of mitral stenosis. So these are the number of points by which you can differentiate on the bedside whether it is a Austin fin murmur or a mitral stenosis murmur. The points are S1 loud, S1 correct to S1. If it is loud, mitral stenosis. Feeble, Austin fin. Can you repeat, Kapil, so that it's
Yes,
okay?
Sir, S1 will be loud, sir, in favoring mitral stenosis. Opening snap will be there.
Okay.
And pre-systolic accentuation, it will more favor mitral stenosis, sir.
Okay.
And dynamic auscultation maneuvers like isometric hand grip, exercise amyl nitrate. This
Very
helps in
good.
differentiating, sir.
Hand grip
lastly,
is all right. Amyl night, of course, you can. Okay, right. Yes, go ahead.
And development of symptoms like PND favors mitral stenosis. Pulmonary hypertension, atrial fibrillation favors more of mitral stenosis.
Very good. Complications like pulmonary arterial hypertension and atrial fibrillation are points more in favor of associated mitral stenosis rather than Austin fin murmur. In this patient, what do you think? Is it associated mitral stenosis or Austin fin murmur?
Most likely Austin fin murmur, sir.
Okay, because there are multiple points. Feeble S1. There is no thrill at the apex. There is no opening snap. There is no pre-systolic accentuation. All put together, and no pulmonary arterial hypertension, no atrial fibrillation. So all put together, you are strongly in favor of. Findings are strongly in favor of Austin fin. Okay, yes. And next murmur.
Next is a mid-systolic harsh, early peaking murmur, best audible in the aortic area. In expiration and conducted to the carotids, grade is 3/6, sir.
Okay, yes.
Sir, two possibilities are there, sir. It could be an mild aortic stenosis, or the severe aortic regurgitation itself can produce a mid-systolic early peaking murmur.
What is the mechanism?
So, increased LV stroke volume, sir, left ventricular stroke volume.
Large volume of blood is being pumped out because the LV end diastolic volume is very huge, resulting in an early pumping of the blood through the aortic valve that will result in early peaking ejection systolic murmur. So when the patient is having an early peaking ejection systolic murmur, that favors more a large volume of blood being pumped out through the aortic valve in the early phase of the ejection, and that can explain the murmur. What are the mechanisms of mid-systolic murmur or ejection systolic murmur? What are the mechanisms of production of ejection systolic murmur? Kapil?
Due to, sir, first is due to turbulence created due to a stenotic valve, sir.
Very good. Flow across the stenosed valve. Okay, very good. 2.
Next is vibration of the surrounding structures. That is aortic valve and the sinuses, sir. Vibration of the surrounding structures, sir.
No, that is the mechanism of production of the mechanism of appreciation of the murmur. I'm asking you what are the clinical background in which the patient can have a mid-systolic murmur. One you said normal flow through a stenosed valve.
Sir, increased flow through a normal valve, sir.
Increased flow through a normal valve, as can happen in this patient. Okay, third one. Because the ejection systolic murmur is the commonest murmur that you will hear.
Sir, hyperdynamic conditions like anemia, thyrotoxicosis, sir.
Yes, hyperdynamic circulatory states. Very good. 3, 4.
Normal valve, normal flow, structurally abnormal valve, as in bicuspid aortic valve.
Very good. Normal flow, normal opening, normal flow, but structural abnormal. Well, very good.
Then the normal valve and sclerosed, normal valve but sclerosed. That is aortic.
The valve is structurally normal. It is opening normally, but the valve is sclerosed. That can give rise to murmur. Okay. And finally.
And one aortic valve or pulmonary valve opening into dilated chamber, sir.
Very good. If the pulmonary valve or aortic valve is opening to a dilated chamber, that can give rise to a turbulent flow that can resonate in the dilated chamber, can give rise to a mid-systolic murmur. So, mid-systolic murmur is the commonest murmur that you hear. There are many mechanisms, and whenever you hear a mid-systolic murmur, you should try to fix it into one. And in an adult, one of the common reasons for mid-systolic murmur in the aortic area is sclerosed aortic valve. If there is no other explanation, then you can always say that it may be because of the sclerosed aortic valve. Okay, so here it seems that because of the increased flow across the normal aortic valve. And as you rightly said, a mild aortic stenosis cannot be excluded. We can't be certain whether the patient is having a mild aortic stenosis or not. But aortic regurgitation itself can explain the early peaking ejection murmur in this patient. Okay, and last murmur, fourth one.
Fourth one is early systolic blowing, high-pitched murmur at the apex. No conduction, no change with breathing. Better heard in the left lateral portion. Grade is 2/6, sir.
What do you think is this murmur?
So it could be a mild mitral regurgitation murmur.
Okay, why it is early systolic?
Sir, it is intensity is only mild, sir.
All right. Can you explain an early systolic murmur in a patient of aortic regurgitation?
Could be a diastolic mitral regurgitation.
No. Early systolic. It is not a diastolic regurgitation. It is an early systolic murmur.
No, sir. I don't know, sir.
What are the mechanisms of mitral regurgitation in a patient with dilated LV?
Secondary mitral regurgitation. Dilatation of the annulus, sir.
Yes, dilatation of the annulus. And when the LV contracts, what happens to annulus?
Sir, incomplete coaptation of the leaflets producing a regurgitation of producing a mitral regurgitation, sir.
I agree. There is a mitral regurgitation initially, but when the LV contracts, what happens to LV volume? What happens to the mitral annulus?
Mitral annulus decreases in size, sir.
Yes, mitral annulus becomes much smaller. Actually, the mitral annulus size is only 2/3 the size of the mitral in systole. The mitral annulus size is only 2/3 the size of the mitral annulus during diastole. So it significantly comes down. The mitral annulus comes down, the LV comes down. So the coaptation of the mitral valve occurs at the later part of the systole. Initially, it is not possible because the mitral annulus is dilated, LV is dilated, and as the LV contracts and the mitral annulus contracts, the mitral annulus comes down in size, Space also comes down, resulting in a situation where the mitral and the closure or the mitral leaflet becomes okay. So the mitral, initially there is a the size of the mitral annulus is large, the coaptation does not take place, so there is mitral regurgitation. As the mitral annulus size comes down, the LV size comes down, the coaptation becomes possible and the mitral regurgitation disappears. So in a patient with LV dilatation due to aortic regurgitation, you can get an early systolic murmur secondary to the mitral annulus dilatation, LV dilatation, resulting in of the non-coaptation of the mitral. Hello, there is a noise coming.
2020.
Can you
in the back, sir.
can you
2 months on notice.
can you somebody who is talking, can you mute yourself so that you don't disturb others? So the early systolic murmur can be explained by saying that there is an early mitral regurgitation, and as the systolic phase progresses, the coaptation of the mitral leaflets take place, and there is no more mitral regurgitation. Is it clear to you, Kapil?
Yes, sir. Clear, sir.
Okay. So all the murmurs are explained. So ultimately, what is your diagnosis?
Chronic valvular heart disease,
Okay.
severe aortic regurgitation,
Okay.
mild aortic stenosis.
You are not so certain. You can say you better to skip it. Don't say that mild aortic stenosis, because in a patient with a mitral aortic regurgitation, there is a large volume of blood is being pumped out through the aortic leaflet, aortic orifice. If it is a mild mitral aortic stenosis, even most likely there will be a thrill. If there is no thrill and there is an early peaking murmur, go for a flow murmur secondary to large volume of blood being ejected across the aortic orifice. So better to stick to that this is only aortic regurgitation and there is no associated aortic stenosis. But I agree with you that mild aortic stenosis is still a possibility, but the absence of thrill make me think that I will stick to aortic regurgitation only, and the flow is causing the murmur. Okay,
Okay, sir.
and you can say that there is mild mitral regurgitation.
Mild mitral regurgitation, sir.
Okay, what is the etiology?
So etiologies or possibilities could be
Is it a aortic regurgitation due to a valvular cause or due to a vascular cause?
so most likely it's a valvular cause, sir.
Why did you say that? How will you
Sir, in
What are the
vascular, sir, in vascular aortic regurgitation, the intensity of the early diastolic murmur will be higher in the right parasternal, right side of the sternum, sir.
Okay.
That is
It is very often the aortic regurgitation murmur will be louder on the aortic area and on the right side of the right parasternal region. Very good. Additional point. Any other point?
Sir, history-wise, there is no history suggestive connective tissue disorders. The arm span is normal, sir.
Okay, that is
spinal
fine. And any other auscultative?
Sir, peripheral signs of aortic regurgitation are higher, mostly in valvular etiology, sir.
No, it can occur in both, depending upon the severity of aortic regurgitation. Yes, in patients with aortic aneurysm, sometimes they can have severe aortic regurgitation. Any other point? Can you think of any click?
If the click is, sir, it is more of valvular, sir.
No, a click is more in favor of actually vascular cause. But I agree with you that there is a valvular condition where there can be click. What is that condition?
Pulmonary.
Bicuspid aortic valve.
On the aortic side, bicuspid aortic valve can also give rise to aortic regurgitation, and it is most often associated with a click. Actually, the click is more of a feature of aortic stenosis rather than valvular aortic stenosis than aortic regurgitation. Because in aortic regurgitation, valve is structurally abnormal, it cannot dome, it cannot give rise to a click. So when there is a click, you should always suspect in a patient with aortic regurgitation that the vessel is dilated, the aorta is dilated. When the aorta is dilated, you will be able to appreciate a click in the ejection click in these patients. So presence of a click more makes you start thinking that the vessel is the aorta is dilated, and whether the dilated aorta is the cause resulting in aortic regurgitation. So the points by which you can differentiate are: one, the murmur audibility, more on the left side, valvular, more on the right side, vascular. Two, if the patient is having associated ejection click, that will be more in favor of a vascular cause for aortic regurgitation. But the bicuspid aortic valve is associated with the click, and then pure aortic regurgitation is very uncommon. In a patient with bicuspid aortic valve, mostly there will be some degree of aortic stenosis. So these are the points by which you can differentiate whether, and also sometimes you may be able to feel the pulsations of the dilated aorta in the second right intercostal space, and sometimes you may be able to appreciate dullness of the aorta appreciated in the second right intercostal space. So the aortic dilatation can be picked up because of the pulsatile aorta being appreciated at the second right intercostal space, and also you may be able to get a dullness in the second right intercostal space. So all these points put together, it seems that this patient is having a valvular aortic regurgitation. Can you tell me a few reasons for valvular aortic regurgitation? Etiology?
Rheumatic heart disease,
Rheumatic heart disease,
bicuspid aortic valve,
congenital aortic bicuspid, tricuspid, quadricuspid, yes.
infective enterocolitis, sir.
Infective enterocolitis, very good.
Connective tissue disorders, sir.
Connective tissue disorders, but connective tissue disorder mostly it is because of the vascular cause. Aorta is dilated.
Degenerative, sir.
Degenerative, very good. There can be atherosclerosis can give rise to aortic regurgitation. Of course, I agree with you that aortic stenosis is more frequent, but they can give rise to aortic regurgitation. Okay, any other reason?
Sir, mitral annular calcification, similar etiology, but
Mitral annular calcification, how can they give rise to aortic regurgitation?
oh, sorry, sir. Sorry, sir. That is for MR.
Any other reason for valvular cause for aortic regurgitation? Avulsion of the aortic valve. Can you get an avulsion of the aortic valve?
Yes, sir.
When?
Aortic dissection, sir. Extending down.
Aortic dissection, it is not avulsion. I agree with you that aortic dissection you can get aortic regurgitation. It is because of the distortion of the aortic valve resulting in aortic regurgitation. What is the condition? What is the situation where you get avulsion of aortic valve?
Trauma, sir.
Huh?
Acute trauma.
Trauma, yes. Acceleration, deceleration, injury. Road traffic accidents can give rise to, when there is acceleration, deceleration injury, that can give rise to avulsion of the aortic valve. An aortic valve prolapse, just like mitral prolapse, you can have aortic valve prolapse also, and that can give rise to valvular aortic regurgitation. Can you tell me a few mechanisms of vascular aortic regurgitation?
Marfan syndrome,
Marfan syndrome.
Loy's dates,
Okay.
coarctation of aorta.
Where did you say coarctation of aorta?
These are all part of ascending aortopathies, sir.
Okay. So we use the word aortopathy. Maybe due to aortic valve. There may be many points in aortopathy. So aortopathy can give rise to aortic regurgitation. Okay, right? Yes.
Syphilis, sir.
Lytic involvement of the aorta with the aneurysm of the aorta. Very good. Yes. Anything else?
Ankylosing spondylitis.
Ankylosing spondylitis, yes. Systemic hypertension, a very common cause for aortic regurgitation. In systemic hypertension, you can get aortic regurgitation. So there are a number of conditions which can give rise to dilatation of the aorta resulting in aortic regurgitation, and damage to the valve resulting in aortic regurgitation. Okay. So in this patient, looking at the various points, it seems that it's more like a valvular aortic regurgitation. Okay, now go to the electrocardiogram. We'll look at the electrocardiogram. Okay, interpret the electrocardiogram.
So, it only the electrocardiogram.
Oh.
So, normal standardization
Okay.
in sinus rhythm, the rate of 100 per minute. P wave axis is normal axis, sir, 0 to 90. The QRS axis is minus 30, sir. There is left axis deviation, sir.
Okay.
And chamber enlargement, sir. There is a left ventricular hypertrophy is there, sir.
Okay. It's more of a LVH with more of a pressure overload.
Yes, sir. More of pressure overload, sir. Left ventricular
Because
with the secondary.
we are expecting a volume overload, but here the ECG picture is more like that of a
Pressure overload, sir.
pressure overload. What is the difference between pressure overload ECG LVH and volume overload ECG LVH?
Sir, pressure. Volume overload is this will have a diastolic Q wave in V5 V6, sir.
Okay. Narrow,
next
narrow deep Q waves with
narrow deep Q is upright. Secondary STT changes will be seen in pressure overload, sir.
okay.
And the left ventricular activation time is intrinsic deflection time will be higher, more than 30 milliseconds in pressure overload pattern, sir.
Very good. So pressure overload, volume overload is associated with narrow deep Q waves, tall R waves, and upright T wave. So these are three features. One, narrow and deep Q waves, tall R waves, and upright T wave with no ST change.
Yes, sir.
While in pressure overload, the Q wave is not deep, the QRS is not very tall, but it is broad. Usually intrinsic deflection is more than 30 milliseconds, more often 40 milliseconds,
Yes,
and associated with STT changes, where there is ST sagging associated with T wave inversion. Okay, so here it is a volume overload or pressure overload?
Here it looks like a pressure overload pattern, sir.
More like a pressure overload. We are expecting so can you get a pressure overload in a patient with aortic regurgitation?
Yes, sir, we can get, sir.
Yes. How?
It's associated systemic hypertension and aortic stenosis, sir.
No, yes, or even otherwise you can say that actually unlike a mitral regurgitation, which is purely a volume overload condition, aortic regurgitation is actually volume with pressure overload also.
Yes, sir.
And when there is a large volume of blood is coming into the LV becomes more significantly dilated. There can be an increase in the wall stress, and the wall stress is compensated. What is meant by wall stress? Define wall stress.
So wall stress is the product of pressure radius divided by twice the thickness, sir. PR by 2T, sir. Depends upon three parameters, sir.
But you have to define that first. What is wall stress?
Wall stress is the pressure exerted by the blood in the. No, sir, I don't know the exact definition, sir.
Anybody who would like to define wall stress? Wall stress is the load on the unit area of the myocardium. Most common one is in unit. It is a unit area. Now, wall stress is the load on a unit area of the myocardium. And wall stress, when there is a wall stress increases, how does the myocardium bring down the wall stress?
By hypertrophy of myocytes.
Yeah, increasing the size of the myocardium. So it is a wall stress is actually a load on the unit area of the myocardium. So when the myocardial area becomes more and more, that will bring down the wall stress. So the compensatory mechanism when the wall stress increases is hypertrophy. So this patient may be having because of what are the components which can contribute to wall stress?
Sir?
What are the components which contribute to wall stress? Well, you said just now told the formula. So that formula, what are the things which contribute to wall stress?
Sir, intraventricular pressure, radius and thickness, sir.
The pressure and radius are they increase the wall stress, and the thickness reduces the wall stress.
Yes, sir.
Okay. Yes. Okay. So he may be having some increase in the wall stress, resulting in some degree of left ventricular hypertrophy. Okay. Right. His ECG was taken when he had an arrhythmia, and this is the ECG.
Yes, sir. And there is associated left atrial enlargement. So there is associated left atrial enlargement also, sir.
I agree with you that there is a there's a because in V1 it seems that the inverted portion of the P wave is occupying an area equal to or more than 1 small square. So I agree with you that there is a possibility that there is some degree of left atrial enlargement. It also indicates that probably the patient is developing some degree of LV dysfunction, and as equivalent to that, or maybe because the patient is having some degree of mitral regurgitation, that also has contributed to the left atrial enlargement. So that is
left anterior hemiblock is also there, sir.
The left axis deviation that can be that may be because of the left anterior hemiblock. Okay, very good. Okay, now what is it? This is the ECG taken during arrhythmia. What is this arrhythmia?
Sir, this is narrow-QRS tachycardia.
Yes.
Regular rhythm.
Okay.
Rate is around rate is more than 120 per minute, sir.
Maybe around 150.
It's 150, sir. Actually, it's 150 per minute.
Okay.
Narrow QRS. There are inverted P waves inverted. Sir, there are some P waves falling in 2-3 AVF immediately after the QRS.
It's inverted actually. Why didn't you say? Why did you withdraw that? It seems that it's inverted here. It's inverted.
Yes, sir, it is inverted here, sir. And upright in AVR, upright in AVL, and upright in V1, sir.
Okay.
So this could be supraventricular tachycardia, atrioventricular AV nodal reentrant tachycardia.
Or do you think it is a AV reentrant tachycardia or AV nodal reentrant tachycardia?
It can be both, sir. It can either be both, but features favoring AV RT, AV atrioventricular reentrant tachycardia is there will be ischemic appearing ST depression in V5, V6, and there will be AVR ST elevation. So these are some features which has been described in literature favoring AVRT, but otherwise there are no specific features which can differentiate AVRT and AVNRT.
But in general, I would say that if the P waves are submerged inside the QRS complex or partly inside the complex and partly outside, that will be more in favor of AV nodal reentrant tachycardia, AVNRT. But if the P wave is outside the QRS complex, you must always start suspecting whether the patient is having, whether it is an AVRT.
Yes, sir.
Why it is that way?
Sir?
Why it is that way? Why it is that in AVRT, the P cannot be submerged inside the QRS complex, while in AVNRT, the P can be submerged inside the QRS complex. Why it is so?
Sir, I don't know the exact reason, sir.
Any one of you? Why I'm making a statement in AVNRT? The P can be submerged inside the QRS complex. But in AVRT, the P can never be submerged inside the QRS complex. Explanation.
Sir, the refractory period of
what is the usual re-entry circuit in a patient with AVRT?
Sir, in AVRT, it can either be orthodromic or antidromic, sir.
Mostly
it is antidromic, sir. Orthodromic, sir.
What is the percentage?
80%.
No, 80% is orthodromic and 20% is antidromic. Mostly it is orthodromic. So what will happen? The impulse travels down through the normal pathway.
Sir, the antegrade limb is through the AV node, sir. The retrograde limb is through the accessory pathway in orthodromic AVRT, sir.
Very good. Yes. So the impulse travels down the normal pathway through the AV node into the bundle of his, excites the ventricular myocardium, and then it enters the atrium and produces the atrial wave. So the myocardium is already, the LV myocardium is already excited. It is the QRS is already formed. Then only it enters the atrium. So that is why in AVRT always the P wave will be outside the QRS complex.
Okay, sir.
But in a patient with AVNRT, what is the problem?
Sir, both the antidromic and the orthodromic limb is within the AV node itself, sir. Only through the fast pathway and the other is through the slow pathway, sir.
Yes.
There is no involvement of ventricle here, sir.
Okay.
it is within the conducting tissue itself, so the P wave may not be seen.
And also the reason is that when the conduction takes place, the antegrade conduction, the conduction to the LV is through the slow pathway, and conduction to the atrium is through the
Fast pathway.
fast pathway. So when it by the time it spreads into the ventricle, it has already reached the atrium because of the fast pathway, and hence the atrium and the ventricle can contract together, and that will result in P being submerged inside the QRS complex, or partly inside the QRS complex and partly outside the QRS complex. So these patients can. So when the P is outside, you must always suspect whether the patient is having AV, RT, rather than AV and RT, whether it is an AV, RT, that should be in your mind. So this patient has got the P wave outside the QRS complex, so always a possibility of AV, RT should be in your mind. But on the regular surface electrocardiogram, we have not picked up any WPW. So whether it is a concealed WPW is a possibility. So he had a supraventricular tachycardia, which will explain his episodes of paroxysmal palpitation. Okay. Yes.
Okay.
Now coming to X-ray chest. Okay. Oh. X-ray chest.
So, chest X-ray, PA view adequately exposed. There is no rotation, sir.
Okay.
So it looks like a slightly overexposed film, sir. All the
No, I agree with you. There is a slightly overexposed, and also it is not a good inspiratory film. Actually, it is a mid-inspiratory film. Okay, right? Yes.
Sir, coming from the left side, the aortic knuckle is prominent, sir.
Very good.
The pulmonary artery is not dilated, sir.
Very good.
The left ventricle appears to be left ventricle is dilated, sir. Sir.
Left atrial appendage.
Left atrial appendage. There, no, sir.
So you are right.
Appendage is not dilated, sir. There is no
left atrial appendage is not dilated. Very good. Yes.
The left ventricle is dilated, sir.
It seems that LV is dilated, and there is a cardiac enlargement also. So what about the right side?
Right side, right atrium. It's up to only 3 right atrium is not that much dilated, sir.
Yeah, the right atrium is not dilated, and there is some suspicion that maybe aorta may be slightly larger than normal. I think here it is aorta is going like this, and so maybe aorta is slightly larger than normal. Okay, right? Any left atrial enlargement?
There is no double density sign, so left atrium is not enlarged, sir.
Unlikely that there is any significant mitral regurgitation, and mitral stenosis is practically ruled out because there is no evidence of any. So, X-ray, does it agree with your original diagnosis of aortic regurgitation?
Yes, sir. It is
Yes. Okay.
aortic regurgitation.
Okay, so now we'll go to the echo.
Yes, sir.
Okay, what do you find here?
Sir, the first one is the M mode across the mitral valve, sir.
Okay.
Across the mitral valve. And the LV dimension, EF is 60%, sir.
Okay.
The LV dimensions are 64-43, sir.
Now,
LV is dilated, sir.
yeah, very good.
And there is a PML, postmitral leaflet. There is some fluttering seen at the postmitral leaflet, sir.
Not how can there be fluttering in the posterior mitral leaflet? Okay, I agree with you. There is some posterior mitral leaflet.
Normality.
But you can see some fluttering movement here.
Okay.
Can you see some vibrations here?
Yes, yes, sir. There is in the
This shows actually there is a vibration. These are the fluttering movements that you can see in the anterior mitral leaflet or the mitral valve in a patient with aortic regurgitation. So he's having some flutter movements of the anterior mitral leaflet. There is no evidence of mitral stenosis because the posterior mitral leaflet is moving away from the
anterior
mitral leaflet. So there is no evidence of rheumatic mitral stenosis. And whatever you are seeing is some fluttering movement of the anterior mitral leaflet. So you most likely is diastolic rumble is because of the
murmur.
Okay, right, yes.
Sir, the aorta dimension is 36-31, sir.
Okay. The aorta is
almost
slightly
nearly 1, sir. Right.
Slightly dilated, not grossly. I agree with you that is a. Okay, now let's go to the next one. Oh, okay. Now let's look at here.
Yes, sir.
Okay, right. Yes, what do you find here?
It's a parasternal long axis window showing mitral valve leaflets are moving normally, sir. Expression is normal. LV is dilated, sir.
Okay,
Aorta is not that much dilated, sir. Aortic leaflets are also moving normally. There is no mitral stenosis or aortic stenosis, sir.
okay,
The parasternal short axis at the midventricular level, at the basal level, sir.
okay,
Mitral valve leaflets open normally. Aortic
Okay.
short axis, tricuspid aortic leaflets, sir.
very good. There's a large, can you see a large regurgitant orifice?
Yes, sir. There is a large regurgitant orifice.
Yes, there's maybe the aortic valve is structurally abnormal and it is not able to close normally. There is a significant regurgitant orifice visible in the short axis view at the level of the aorta. Right, very good. Yes.
LV parasternal short axis at the level of LV is normal, sir. The pulmonary right ventricular outflow tract pulmonary arteries are not dilated.
Very good.
No
And you
evidence
can
of
see-
pulmonary hypertension, sir.
Okay, very good.
There is a severe aortic regurgitation color window, sir. Apical 5-chamber view showing severe aortic regurgitation with the jet impinging on the mitral jet also, sir.
Okay.
The jet is reaching almost the middle of the left ventricle, sir.
Okay. What are the points, echocardiographic points by which you diagnose severe aortic regurgitation?
Sir, first, the regurgitant jet occupying 65% of the left ventricular outflow tract cross-sectional area, sir.
Very good.
In parasternal long axis window, the regurgitant jet reaching the middle one third of the left ventricle. Then quantification.
By if it reaches beyond the middle one third, or rather, it goes beyond the tip of the anterior mitral leaflet, maybe a point for you to say that there is a severe aortic regurgitation. Okay. What are other points?
Sir, quantifying parameters is regurgitant volume more than 60 ml.
Very good.
Regurgitant fraction more than 50%,
Very good.
sir. Effective regurgitant orifice area more than 0.3.
Very good.
Vena contracta more than 0.6, sir.
Okay, very good, excellent. And if this one, and also if you can look at the descending thoracic aorta.
Sir, diastolic flow reversal in the descending.
And if the end diastolic velocity, what should be the end diastolic velocity for you to definitely say that?
So more than 22 centimeter per second, sir.
Okay, if it is more than 20 centimeters per second, that will be diagnostic of severe. Very good, excellent, Kavil. I think you are really doing very well. There is no mitral stroke, right? There are no tricuspid.
Mild mitral regurgitation is there, sir.
And anything more that you can do? Anything to do with the pressure of time?
Yes, sir. Pressure of time less than 220 suggestive of severe aortic regurgitation. 200.
200, not 220. 220 is for mitral
200.
stroke.
Sorry,
Okay.
sir. 200, sir.
Yes. Okay. Right. There's nothing special. Okay, we'll go to the next one. Ejection fraction. There's nothing special. Okay. So I'll just prepare a small slide for so valvular and vascular we have already mentioned. Murmur best audible in the third left intercostal space along the left sternal border. S2 feeble. No ejection click except in bicuspid aortic valve. Goes more in favor of valvular. Vascular, dullness of the second right intercostal space. If it is dull, it indicates that the aorta is dilated. Murmur better audible on the right side of the sternum. S2 is loud and ejection click may be audible. All these things go more in favor of vascular cause for aortic regurgitation and the first one for valvular cause. The assessment of severity aortic regurgitation clinical, nocturnal angina, peripheral signs, down and out apex LV type, feeble S1, paradoxical split S2, length of early diastolic murmur at least 50% of diastole except in acute aortic regurgitation, early peaking ejection systolic murmur at the aortic area, Austin Flynn murmur, and third heart sound. Usually third heart sound indicate associated LV dysfunction. So these are all clinical points by which you can assess the severity. To repeat, nocturnal angina, peripheral signs, down and out apex, fevulous 1, paradoxical spiritus 2, length of ADM. That's not a very important point, but still it can be included. At least 50% of diastole except in acute AR. Early peaking ejection systolic murmur at aortic area. Austin Flynn murmur. S3 indicate LV dysfunction in a patient with aortic regurgitation. ECG wise, LVH mostly volume overload. Associated STT changes indicate associated concentric LV hypertrophy. Our patient has got STT changes indicative of some degree of concentric LVH. Extra chest cardiomegaly, cardiac apex dipping down below the diaphragm, and there may be features of heart failure like upper lobe vessel prominent, especially if the patient is having LV dysfunction. So these are the various parameters. Echocardiographic assessment of aortic regurgitation, mild, moderate, severe. We have already mentioned that. Regurgitant volume, more than 60 indicates severe. Regurgitant fraction, more than 50% indicates severe. Vena contracta, more than 6 millimeters indicate severe aortic regurgitation. Regurgitant orifice, more than 0.3 centimeter square. Jet width, more than 65% of the aortic ALV outflow. Area of the regurgitant jet parasternal short axis view, more than 60%. All indicate severe aortic regurgitation. You can also find here the mild and moderate grading also. Pressure half time more than 500 mild to 200 to 500 moderate, and severe less than 200. And diastolic flow reversal in descending thoracic aorta, and diastolic volume more than and diastolic velocity more than 20 centimeters per second. All this indicates severe aortic regurgitation. So we already mentioned the severe aortic regurgitation. And treatment of aortic regurgitation, medical, mild or low moderate aortic regurgitation, only follow-up is required. If the patient is having moderate to severe aortic regurgitation, you may use vasodilators like nifedipine, amlodipine, hydralazine, or AC inhibitors. It has been reported that studies are with nifedipine that sometimes these drugs can reduce the progression of aortic regurgitation. So you may try that medically. Surgical treatment, indications for surgical treatment are symptomatic severe aortic regurgitation, asymptomatic severe aortic regurgitation, if the patient's LV ejection fraction falls below 50%, that's a class 1 indication. Along with other open heart surgical procedure, if the patient is to undergo any other surgical procedure, like for example CABG, he can undergo aortic valve replacement with asymptomatic severe aortic regurgitation. If the LV and systolic diameter more than 50 millimeters, that's a 2A indication, not a very strong indication, but 2A indication. And if the LV and diastolic dimension more than 65 millimeters, very weak indication, or 2B. So if it is more than 50 millimeters and systolic dimension diameter, that is more likely for a stronger indication for aortic valve replacement. While if the LV and diastolic dimension is more than 65 millimeters, still you can consider aortic valve replacement, but not a strong indication. Asymptomatic, moderate to severe aortic regurgitation, in a patient with completely asymptomatic, moderate to severe aortic regurgitation, along with other open heart surgical procedures like CABG, you can subject the patient for an aortic valve replacement. That is a 2A indication. So what are the surgical procedures that can be carried out? One is aortic valve replacement. Two is aortic valve repair in patients with aortic valve prolapse, aortic valve avulsion, aortic perforation. Sometimes repair is enough. Modified by Benthal procedure if the patient is having aortic regurgitation secondary to aortopathy. Surgical mortality, especially the higher mortality, is for Benthal procedure, which is 8%. While for a regular surgical valve replacement, it is around 3%. The surgical mortality increases when the patient develops LV dysfunction. Interventional treatment, aortic valve replacement, transcatheter aortic valve replacement is being tried. but it is not as effective as an aortic stenosis. So this is still in the experimental stage. But if somebody asks you in the examination, you can say that transcatheter aortic valve replacement is being tried in patients with aortic regurgitation. So that is about aortic regurgitation. Any doubts? If you have, you can ask now. Any doubts? Kapil, do you have any doubt?
Sir, I learned a lot of points, sir. It was very useful, sir.
Any doubts? Anybody having any doubts? Okay, so I think it's now going to be 9 o'clock. So I think we will close the session. And next week we will have some spotters, because in the examination may be showing you some spotters. Maybe an ECG, maybe an echo, maybe an X-ray, or maybe pressure tracing, whatever it is. We will have a mixture of all those in the next week's discussion, where we will discuss about spotters, especially ECG, X-ray, pressure tracing, all those things. Okay.
Okay.
Any doubt? Any doubt?
No, sir. No.
Okay. Right.
Yes, thank you very much, sir.
Right. Good night. Good night.
Good night, sir.
See ya. Sia, are you there? Sia, are you there? Okay, right. She's not there. Hello? Hello, Sia, are you there?
Recording stopped.